Here we present a single-position robotic-assisted laparoscopic right ileal ureter interposition. The patient is a 45-year-old female with a history of cervical cancer in remission, presenting with right ureteral stricture. Patient was managed with nephrostomy tube and elected to undergo robotic ureteral reconstruction. Preoperative imaging with nephrostogram demonstrated a panureteral stricture at the right UPJ. Ileal ureteral reconstruction is used to repair extensive ureteral defects through replacement with ileal bowel segments. Patient was prepped and draped in the usual sterile fashion. Ports were placed in standard position with the right-sided ports tilted up and left-sided ports tilted down. This allowed for better reach towards the right UPJ and for the patient to remain in single dorsal lithotomy position throughout the entire procedure. Following port placement, we mobilized the colon and cochorized the duodenum, after which the lower pole of the kidney was elevated to identify the ureter. Once the ureter was noted to be completely entrapped within fibrotic tissue, the intraoperative decision was made to abandon any onlay repair and instead perform an ileal ureter interposition. We dissected and dropped the bladder by incising the peritoneum lateral to the medial umbilical ligaments on either side. By mobilizing the bladder and developing the space of Ritzius, we were able to swing the bladder up towards the right. We then turned our attention to harvesting the ileal ureter segment. Once the terminal ileum was identified, a 25 cm segment of terminal ileum was isolated 20 cm from the ileocecal junction. A deep mesenteric defect was then made on the distal side, and we created a 5 cm discard segment on the proximal side. This was done in a similar fashion to an intracorporeal ileal conduit formation. With the bowel placed anteriorly and the ileal ureter placed posteriorly, indocyanine green was used to assess for viability of the bowel and harvested ileal ureter segment. A side-to-side bowel anastomosis was performed to reestablish continuity of the bowel using a 60 mm load, with one intussuscepted into the other to perform the anastomosis. We then closed off the apical defect with a 60 mm stapler. Once bowel continuity was reestablished, the staple line from the distal aspect of the ileal ureter was removed. A cystotomy was created to perform an anastomosis of the distal ureter to the bladder using 3-0 V-lock suture. By creating the distal anastomosis first, we were able to advance a counsel tip catheter up the cephalopod portion of the ileal ureter, and hence more easily advance the wire through the proximal anastomosis and into the pelvis. This aided in placement of the stent into the renal pelvis. Advancing the wire without the counsel tip catheter would likely be impossible as it would get curled within the ileal ureter. Following completion, the bowel bladder anastomosis was identified to be tension-free and watertight. For the anastomosis between the renal pelvis and proximal aspect of the ileal ureter, we dissected up towards the lower pole of the kidney and identified the distended renal pelvis. A dissection was made below the ureteral stricture to grasp and handle the ureter. We then spatulated the renal pelvis on the posterior aspect with an immediate efflux of high-pressure urine upon entry. This suggested that we were above the area of the stricture. A 2.5 cm horizontal incision was made on the anterior but proximal aspect of the ileal ureter to enter into the lumen. A spatulated Bricker-type end-to-side anastomosis was created using running 3-0 vicryl suture. A double J stent was placed up into the pelvis through the anastomosis. Prior to closing, the anastomosis was noted to be tension-free and watertight. When the bladder was distended again, there was no evidence of significant leak from either the bowel bladder nor the bowel pelvis anastomosis. Total operative time was 218 minutes and the patient recovered with an unremarkable postoperative course. Patient was discharged on post-op day 2 with imaging demonstrating preserved renal function. In summary, robotic ileal ureteral reconstruction is an innovative strategy for the reconstruction of extensive ureteral defects.